All right, when we talk about using adrenocorticoids therapeutically, it's important to remember the physiology of the production naturally of these naturally occurring steroids in the body, because the rule of thumb is really that the pharmacologic action of these medications is really just an extension of their physiologic effect. Remember that corticosteroids, they are lipid soluble, they're created out of modified cholesterol. And all they need is a glucocorticoid receptor, a GR, glucocorticoid receptor. And because these are lipid soluble substances, they are able to dissolve right through the plasma membrane, find their glucocorticoid receptor, which is generally in the cytoplasm. When they bind to it, we now call that a steroid receptor complex. And that complex, then, with the steroid and the receptor together, translocates into the nucleus, where it is able to read the DNA for any recipes it needs to make proteins. So, when we use these medications, generally we are going to be suppressing inflammation or immune responses in autoimmune diseases or different inflammatory diseases. So, we are going to regulate the production, the release of various steroid hormones. So, we're really just extending by enhancing the physiologic effects of the naturally occurring and produced steroids. Here we have a table of the various glucocorticoids and mineralocorticoids that are used in treatment. The ones that we see in caps at the beginning are caps to indicate that these are the preferred and most commonly used substances. I do want to make a note that depending upon which pharmacology textbook you're reading, depending upon who wrote it and what their individual experience with treating patients is, you won't see that there's a ton of continuity between preferred medications between textbooks. So don't be surprised if you see things written differently, or you work somewhere or have some sort of experience where there's different choices. But as it stands now, we have our list of most commonly used glucocorticoids. Again, the ones in caps, dexamethasone and prednisone, are the two most commonly used glucocorticoids in the United States within clinics currently. There's also fluticasone, bechamethasone, prednisolone, and triamcinolone. Equal potency to these substances is cortisol and hydrocortisone, and our mineralocorticoid that we'll see used is fludrocortisone. So all of these things are just our synthetic substances that are going to naturally mimic either our glucocorticoids or our mineralocorticoids made by the adrenal cortex normally. So in looking at the application of these substances, again, we first have to recall what the naturally occurring physiologic response is to produce these, what their effects are in the body physiologically, and what an excess of these substances look like. And that will help you understand the pathology of these disorders that we then need to treat pharmacologically. So if we think about the pathogenesis, the creation of these disease states, and link that to the physiology that we would want to see, we can choose what type of preparation we want to use. If we want to use a glucocorticoid or mineralocorticoid, or an agonist or antagonist of either one. When we look at general uses of glucocorticoids, remember that our commonly thought of one is our cortisol. When there is any type of adrenal insufficiency, so the adrenals are not producing the substances that they should, then we can think about giving a true hormone replacement. So in adrenal insufficiency, we can use agonists. More commonly, what we see now are these preparations of synthetic cortisols through these cortisones, these various glucocorticoid preparations used to treat inflammatory disorders and autoimmune disorders. So we're suppressing the natural inflammation response and immune response that's mediated by various pathways involving arachidonic acid and also involving these specialized immune cells. So long-term release of cortisol does depress immune function. So if we give a synthetic cortisol, if we give a glucocorticoid, we will still get the suppression of the immune system. And we'll see this used for a variety of different reasons. So very severe asthma, we have inhaled glucocorticoids, rheumatoid arthritis, you can give oral preparations of these medications. The other helpful thing that you can do with joint issues is directly inject the glucocorticoid into the joint space. So when we're giving something inhaled or injection into a limited, like a joint area, we're giving it more locally. And that helps to limit some of the systemic side effects that we would see giving these in a more widespread fashion. So when we're looking at these inflammatory or immune regulated disorders and we're giving glucocorticoids, we call that type of care palliative care, and that is addressing the symptoms and the comfort of that individual. These preparations do not cure the disease. They do not stop the immune system from attacking itself or stop inflammation or make the disease go away, but they do make it easier to deal with by limiting the symptoms. When we give an antagonist to the glucocorticoid system, so blocking the binding of steroids to their receptors, you might see that use in a variety of hypersecretion things. One of the main hypersecretion disorders is Cushing syndrome, which is a general hypertrophy and then increased functionality seen in the adrenal glands. So there's very increased ACTH in Cushing's disease, which will then increase cortisol. So we can give antagonists to help resolve that. Mineralocorticoids we can also see used for adrenal insufficiency, although it's more common to see glucocorticoids used for this. Because there is general hypertrophy of the adrenal glands in Cushing syndrome, not only do we have increased cortisol, there's also increased levels of things like aldosterone, which will raise the blood pressure. So giving an antagonist to the mineralocorticoid system will help address the systemic hypertension that we see in Cushing's disease. So we can agonize the system or we can antagonize the system. So increase activity versus decrease or block activity. In thinking about the side effects of glucocorticoid administration, again, we need to remember the physiologic action of substances like cortisol in the body naturally. So remember that things like cortisol, they promote catabolism of proteins and gluconeogenesis. So we're breaking down our energy stores and liberating glucose into the bloodstream. So you will see elevated blood glucose in some cases. And if you're using too high of a dose, you can actually see fat maldistribution, very similar to what you'll see in Cushing's disease. But because it is through administration of a medication, we call it pseudo-Cushing's disease in that it is induced by some other mechanism rather than ACTH overproduction. We also know that glucocorticoids help with the formation of glucose and also the breakdown of proteins into amino acids. And it's really important not to let amino acids build up in the bloodstream because they can actually cause neurotoxicity. So what you'll see with the glucose is that liver glycogen levels are going to go up because we're storing more glucose, and then the liver is replacing stores of glycogen more rapidly because we're breaking them down more rapidly. you'll see that fasting blood glucose levels go up, as I mentioned above, and also urinary nitrogen output will be increased because that is a component of the urine through which we excrete residues of amino acids. Also, the reason that we use synthetic steroids, these glucocorticoids, is to suppress an immune response or to an inflammatory response. So that's the desired response. We want to reduce those things. However, there is a therapeutic range to that. We want to reduce it enough that we're not seeing symptoms or at least flares of their disease so that it's well controlled. We don't want to suppress the immune system so much that we see that patients are getting recurrent infections. So do keep in mind that although this is the main reason we use these medications, we don't want to suppress activity too much. We want to preserve some of that natural immune and inflammatory process. One of the ways that we see glucocorticoids act is in their interruption of the inflammatory process. And they are very, very potent anti-inflammatory medications. They're so good at what they do that we actually named a class of things like NSAIDs, non-steroidal anti-inflammatory drugs, NSAIDs, just to differentiate between them and steroids. Because if there were no negative side effects of glucocorticoids, we would use them for everything inflammation related. They're great at it. And the reason they're great at it is because they inhibit truly at every step the production of inflammatory proteins. So when we think about a cell dying, so if this is a cell and now it's dead because it was attacked by the immune system, it had something bad in it, it was damaged or it's infected, the body will break that cell down and it will essentially liberate the cell components from the phospholipid components to start to break it down to be removed from the body. But there's also some physiologic activity to those byproducts. The enzyme that breaks down the phospholipids in the cell membrane is called PLA2, and you see it written out here, phospholipase A2. And once you have induction of this enzyme, phospholipase A2, it leads to, again, these phospholipids being broken down into a substance called arachidonic acid, AA. And whenever arachidonic acid is around, it leads through several steps of what's called the arachidonic acid cascade to the formation of pro-inflammatory proteins. One family of these is called the prostaglandins, your PGEs. There's also the leukotrienes, LKEs, LTEs. These are pro-inflammatory proteins, and wherever you see these around, they are going to promote the inflammatory response, which is not all bad. Even though you get redness and swelling and pain and loss of function, the inflammatory response allows white blood cells to leave the vascular system to get to that area so that they can find pathogens and kill them, even if they're inside of cells. So the way that glucocorticoids work is that they inhibit this initial enzyme induction. If we inhibit phospholipase A2, we inhibit prostaglandin production, and then we limit inflammation. So for chronic inflammatory disorders like arthritis, like Crohn's disease, these can be used to decrease the long-term inflammation that we see and then reduce the symptoms of that disease. We also see that the internal cell function is decreased when we give glucocorticoids, so the intracellular synthesis of lipocortin or annexin 1, and then that COX-2, which we also call inducible COX, which only pops up in the case of inflammation, not basal functioning of the cell. Those things are reduced as well. So truly every single step in the inflammatory response is inhibited because of these actions. Again, inflammatory responses are painful, so we want to suppress them in some cases, and definitely in chronic disease states, but we also want to be able to preserve some of this functionality so that we're able to fight infection and then limit the engagement of the immune system. If an inflammatory response works appropriately, we don't ever have to have the immune system involved. The pharmacokinetics of glucocorticoids directly mirrors the physiologic kinetics of our cortisol. Remember that cortisol is reversibly changed to cortisone, and cortisone, as soon as it binds to a glucocorticoid receptor, reversibly changes into cortisol. So essentially, we're just giving a medication that changes into cortisol, and that means that whatever the activity is of cortisol naturally is going to be enhanced or facilitated with the synthetic medication. So the kinetics of it, if it's given systemically, so through a pill like in prednisone, hydrocortisone, in those systemic preparations, we see that about 10 to 20 milligrams daily is naturally produced in the body. So that can be altered with the dose that we give, and with normal kinetics, the higher the dose, the faster things are removed from the body systemically. And also naturally occurring, we see that cortisol, it spikes throughout the day, and that is in relation to the circadian rhythm, because ACTH is highly dependent upon the circadian rhythm controlled by the suprachiasmatic nucleus and the pineal gland and the release of melatonin in response to sunlight. The half-life of something like cortisol is about 60 to 90 minutes, and most of it travels around the body via plasma proteins. The most prevalent one in the body is albumin. The other 25% rides around unbound. And remember, if it's bound to something, it cannot have activity because it's like it's in a car, it's just traveling around. When it becomes unbound, we call it free drug, and that allows it the ability to go have activity in cells. So normally we see half-life of it, again, about an hour to an hour and a half, but that does become increased by the tissue sensitivity to these substances. And tissue sensitivity goes up, meaning that cortisol will have longer action and activity during periods of physiologic stress. In cases of hypothyroidism, when one part of the endocrine system is depressed, we'll see that the other parts end up with some alteration as well. And in hypothyroidism, you can see increased cortisol half-life. Also, liver disease, that has to do with metabolism and then excretion. So we have a longer half-life. It's around for much longer before it's broken down or deaminated. And if you're giving then large doses of hydrocortisone, and for very severe types of type 1 anaphylaxis, your immediate hypersensitivity, where we call that an allergic reaction. So perhaps it would be an allergic reaction to a bee sting. There's very, very high doses of hydrocortisone given. Hydrocortisone binds to the glucocorticoid receptors. It's converted into cortisol, and we can overwhelm the enzymes that would normally break down cortisol by essentially flooding them. We saturate the receptors and we give it too much to break down so that the half-life is then extended because the amount of available cortisol is now increased beyond the body's capacity to break it down and then remove it. Remember that glucocorticoids, because they are also lipid soluble, they look just like our naturally occurring steroid hormones, they are able to traverse right into the cell because they can dissolve right through the phospholipids. They find their receptor in the cytoplasm, the glucocorticoid receptor, and lucky for us, we have glucocorticoid receptors in nearly every tissue of the body. That means you can put hydrocortisone on any tissue in the body, and it will have a receptor there that it can bind to. And once it binds to its receptor, it translocates into the nucleus here. And once it's in the nucleus, your DNA, remember, that's your recipe book. It can read the recipe book and pump out through transcription and translation more proteins. So when we're giving a hydrocortisone, when we're giving a synthetic cortisol in general, then we're really increasing the amount of anti-inflammatory proteins while decreasing the production and then amount of pro-inflammatory proteins. So they're truly interfering or enhancing with the protein creation in the cell. So this is a lot different than other medications. Steroid drugs actually work inside of the cell. You just need to know your physiology because they're reversibly changed into cortisol as soon as they get into the system. So once they're bound, they are changed. So they are going to work in this exact same way inside of the nucleus. On this slide, we have the side effects that I talked you through before. We also have their general mechanism of action. We've already mentioned that they bind to steroid receptors, or GR, or glucocorticoid receptors, which are in nearly every tissue in the body. Not only that, because thyroid receptors are so bizarre and have a little bit of intracellular activity, they can also bind to thyroid receptors and alter thyroid activity. As a pharmacologist, one of my favorite terms is called orphan receptors. What a great name. They don't exactly fit into any of the big receptor families that we have, but they still exist and they still matter. They're just a little bit different and they don't really have special names and belong to special classes. But we can track that glucocorticoids bind to these many types of different orphan or unnamed receptors in addition to glucocorticoid receptors. So remember that we have various side effects. So we have the things that we might want to use them for, like their anti-inflammatory effects, which we do consider generally a deleterious effect of too much hormone production. So we get an increase in glyconeogenesis, catabolic effects, breaking down proteins, liberating glucose, getting amino acids in the system, and then our anti-inflammatory effects. We already mentioned that we're going to increase the blood glucose, block inflammation. That's going to be why they're used. We're taking advantage of that. But do know that without a strong, intact inflammatory response, there is more susceptibility to disease. The other thing that you will see with glucocorticoids, besides depressed inflammation response, and if you have an inflammatory response that doesn't resolve the infection, it leads to an immune response, so you get immune suppression as well. It also has effects on connective tissue, and those connective tissues involved are mainly going to be muscle related. So with long-term use, especially at higher dose, you will see muscle weakening because we start to lose muscle mass. There's lots of stored glycogen in muscles, so if we're reaching to the muscles for glycogen and liberating it, then the muscles have less energy and they're going to start to lose mass. The other connective tissue that is really, really strongly involved with glucocorticoid administration is bone tissue. So here we have the term osteoporosis, and osteoporosis, the pore in there is referring to the fact that large spaces or pores develop in the trabecular or kind of honeycomb inner part of the bone. And that's pretty progressed bone mass loss. When we start to just have lowered bone density, we call that osteopenia, and penia of anything means deficiency of or low levels of. So osteopenia is going to be low levels of bone mass, and there are very commonly recognized types of osteopenia and then osteoporosis caused by long-term administration of these glucocorticoid substances. So keep that in mind when we think about their effects. Know the peripheral effects of cortisol release, of long-term cortisol release, and the deleterious effects of it. Some of them we're going to take advantage of for giving this medication, like immunosuppression, inflammatory suppression, but we're also still going to have the other effects that we don't like as well. So we'll have to develop a plan for dealing with those, either with using the lowest dose available, using a local administration rather than systemic. So fluticasone, for example, is contained in a lot of nasal sprays. So that would be a local administration. There's hydrocortisone cream or sprays when we're dealing with rashes or types of skin irritation. That's more local. And remember, the general rule in pharmacology is if it's local, we can usually count on the fact that you're going to have less side effects than you would see systemically. So getting creative with your thinking about how to administer and exploring possible options for local administration over general peripheral systemic administration. As we mentioned, because we have these glucocorticoid receptors on really almost every tissue in the body, very widespread effects, definitely on connective tissues, and definitely on glucose levels. The shortest term of treatment that you can give is usually okay. Short-term use is usually just fine. So if you have a patient, I'll use the bee sting for an example again, you'll give them a prednisone pack to deal with the inflammatory and type 1 anaphylactic hypersensitivity. And they take a really high dose of something like prednisone on the first day, and then they take a lower dose the next day and a lower dose the next day. So that's called a taper. And that's only for, less than a week. And we can count on short administration like that to be generally safe. That's not going to be long-term enough to cause any long-lasting effects to the bone or to the muscle. However, you will see more long-term use with a variety of these chronic inflammatory diseases where you might see that. Another short-term use where you'll see this, another manifestation of an initial type 1 hypersensitivity is status asthmaticus. And there are a couple of different pathologies that lead to this. We call this status. So status epilepticus is when there's unending seizures. Status asthmaticus is when there's an unending asthmatic attack, which does not respond to typical therapies. And a high dose of glucocorticoids, because it affects the expression of pro-inflammatory proteins in the bronchi, you mainly have leukotrienes that are there. So that is a great way to treat an acute exacerbation, but that's very, very short-term treatment. If you have a patient, though, for long-term asthma, you'll see that the more common way of giving a glucocorticoid is an inhaled route. So the Advair discus, for example, is an inhaled glucocorticoid. That is a local type of administration. It's going to go into the bronchi and hopefully have the bulk of its effects there. But you can see actually a local manifestation of one of the side effects. Because these are anti-inflammatory, immunosuppressive medications, if a patient is not appropriately rinsing out their mouth after taking a puff of their Advair discus, you'll get that drug settling in the mouth and altering immune and inflammatory responses there. When we start to alter the ability to fight things off, you can get what we call a supra infection, an infection on top of something else. And we naturally have yeast in the mouth. We have it all over, but we have it there. And in the use of these inhaled glucocorticoids, you can see the development of something like thrush. And thrush it looks like a white fluffy tongue, and it's really just a yeast overgrowth in the mouth. And that is due to altering the immunosuppression in that area. We're suppressing the body's ability to fight off infections, and that allows yeast to overgrow. An easy way to prevent that is encourage patients to at least drink a sip of water afterwards, but if they can fully swish out their mouth, brush their teeth, that's even better. If they do develop thrush, there is a mouthwash that they can use that kills the yeast. It is toxic if swallowed, so it has to be relegated to the mouth. They have to spit it out right afterwards, and that's taken for a couple of weeks to resolve the thrush. So that's a local manifestation of this. So we have to take into account not only knowing the side effects, but also communication with patients and patient education to try to avoid those side effects. So that's an example of a supra-infection. We can also see this more systemically, resulting in reduced healing of wounds, which requires a variety of minerals, but also the inflammatory response to help the redness and swelling and eventually angiogenesis and tissue replacement to start. So that can be slowed. And also those elevated levels of glycogen breakdown are going to lead to high glucose levels in the blood. And if that glucose isn't appropriately utilized, that fat will accumulate in areas that are not normally the distribution sites, like under the chin, above the collarbones, between the shoulder blades, underneath the abdomen, and it can resemble what we see in Cushing's disease. The effects that we see on the bone are very important. There are different bone cells. The osteoblasts build bone, the osteoclasts are going to be what break the bone down. So we do see that glucocorticoids, they decrease the production of osteoclasts, which sounds good, but it's important that osteoclasts break down bone as it becomes damaged, even in a really small amount. Like when you go for a run, you get tiny little microfractures in your bone. So the osteoclasts work on that area to break down that bone so that in turn the osteoblasts can come and fill in that area with new, fresh, liquid bone, which enhances bone strength. That's why they tell you to exercise for bone strength. Because of osteoclast and osteoblast activity. So we see osteoclasts, they're not making copies of themselves the way that they should. Same thing with osteoblasts. They're decreased synthesis, decreased creation, and we want them to be able to be there because they physically form the bone. So we need not only osteoblasts building bone, we need the osteoclasts to work along with them to provide sites for the osteoblasts to bind and then spit out their liquid bone, which is osteoid. The bone cells themselves, we call them osteocytes. Site is bone, site is cell, and osteo is bone. Their rate of apoptosis or programmed cell death becomes increased. The circulation of these through the canaliculi or small canals in the bone goes down, and then bone quality goes down and bone density goes up. So it's more likely that you see death of bone tissue, we call that osteonecrosis, or fractures within the bone tissue. When we think about dealing with these side effects with bone, we can make a variety of recommendations. So again, think about dosing, using small doses, using more local administration if you can. Because it causes connective tissue thinning, the skin is also connective tissue. So do keep in mind, even if you're giving it through cream or spray, you can see thinning of the tissue at that area. So not only dose, but also length of administration. Shorter administration, less amount of damage. Adding foods that might help with bone density. So vitamin D, calcium containing foods can be helpful. Exercise, as we just said, is helpful. And if we're dealing with somebody who already has low bone mass and they're at more of a risk for fracture, one of the interventions through patient education is really decreased fall risk. So working with an occupational therapist, a physical therapist, to make home recommendations to make car recommendations to reduce fall risk. The number one place that we see falls at home is in the bathroom, so specifically in the shower. So there are changes that people can make to, add a handlebar to the shower, lower the tub if it's available, take away the tub so it's a stand-up shower, add a seat, add a rug so it's not slippery. So fall reduction, risk reduction is important because this is going to be what we see with long-term administration of glucocorticoids. One other note while we're on this, because I didn't mention it before, one benefit that we see with injection of glucocorticoids, so that's another local way of giving these drugs. Let's say, since we're talking about bone, if we're dealing with a patient with arthritis and they're having a flare of either osteoarthritis or rheumatoid arthritis, what we can do is inject the glucocorticoid directly into the joint space. So we're only going to limit inflammatory protein production right there in the articular spaces. Because we know that there are damages that occur to the connective tissue, and we're dealing with connective tissues here in the joint spaces, instead of giving a daily oral medication, we can give these injections. And the way that they can be given is in a way called pulse therapy. So here I have a timeline, and if this is a year that a patient is experiencing arthritic symptoms, we can give an injection really when they have flares. So they could be on their normal NSAID or disease-modifying anti-rheumatoid drugs, and then every couple of months, maybe every 3 months, they get a glucocorticoid injection. 3 months later, they get another, and then so on and so forth. So we're spacing out the administration there, and that's a nice benefit of giving something like a cortisone shot. It's local, it's direct, and we can space it out because it's very potent and anti-inflammatory, and it lasts for a while in that preparation. We just also have to note inhibitors or antagonists in the system. So something that blocks or limits the production of cortisol. You'll see these things used in the case where there's overproduction of cortisol. This can be due to Cushing's disease, which is that high ACTH. Most common cause of Cushing's disease is an adenoma or a benign tumor on the pituitary. So it's an ACTH producing tumor. This can also happen in adrenal carcinoma, in adrenal tumors as well. When you have something in the body increasing cortisol production, we want to decrease that cortisol. Metirapone, aminoglutathione, these are two antagonists that inhibit the synthesis of adrenal corticosteroids. Those are the true antagonists of the glucocorticoid receptors, and they're used for overproduction. There's also some bizarre, or there's one bizarre one, and it's ketoconazole, and that's actually an antifungal drug. That's what you find in those athletes' foot sprays like Tough Actin, Tinactin. That's ketoconazole. And for whatever reason, it seems to inhibit pretty strongly adrenal hormone synthesis. So that can be given. That can be given in local preparations, but when we're thinking about it for these types of disorders, they're given in an oral preparation. So you'd see oral preparations used for very severe fungal infections or long-lasting ones like in toe fungus, which can be very difficult to get rid of, but normally it's given locally. So ketoconazole given systemically can antagonize cortisol synthesis. Also, spironolactone is a diuretic that you can learn more about in my diuretic talk, but spironolactone works physically to inhibit the site of action where aldosterone normally works in the renal tubule. And the aldosterone site of action alters the incorporation of sodium and potassium into the urine, and it promotes the retention of sodium in the bloodstream to raise the blood pressure. So if somebody, like in Cushing's disease, it's general hypertrophy and then activity of the adrenal glands. So not only will you have lots of cortisol, you'll also have lots of aldosterone. So spironolactone kind of does two things at a time. It will antagonize the production of aldosterone, and then it will of its synthesis, and then it will also work as a diuretic to inhibit activity of the pump in the renal tubule that aldosterone normally works on. Finally, with hormone replacement therapy, we can see the administration of the adrenal androgens. DHEA is the main normally produced hormone by the adrenal glands. And also we have androstenedione, so dihydroepiandrosterone is our DHEA, and androstenedione is another adrenal androgen. So we just give preparations that are called that. They're just called by their names. Sometimes you'll see them sold as supplements for testosterone. Because they are in the androgen family, they are associated with testosterone, but they are not going to be associated with any increases that are specifically testosterone related. They don't have a ton of activity with secondary sexual characteristics that you see really develop during puberty. So with any kind of protein deposition, fat distribution, voice deepening, what you do see that happens during puberty is that DHEA is a big player in the development of underarm hair and pubic hair. In adults, it doesn't seem to have that big of a role, and naturally the production of DHEA goes down relatively steeply after puberty. However, you will see DHEA used in women with systemic lupus because it affects a variety of physiologic systems in the body, and also in women with adrenal insufficiency, because DHEA, even though the levels go down as you age, it is still a product of the adrenals. And in females, it's been shown to be relatively important in their libido or sex drive. So it can be given to help modulate libido or naturally occurring levels of, or to maintain naturally occurring levels of DHEA. Okay, hopefully this seems like an easy question by this time. Hormonal steroids most influential on intermediary metabolism. So there was one class of substances that we mentioned have to do with metabolism and glucose and energy. It was not androgens. Those are gonadal hormones. It is not catecholamines. Those are sympathetic types of neurotransmitters. Glucocorticoids, glucose, metabolism. That sounds good. Let's leave that for a second. Mineralocorticoids, that's our electrolyte balance, or sodium and potassium. So that's not it. So our correct answer here would be glucocorticoids. If you couldn't answer that question, let me know. Send me a message, leave a comment. Hopefully, we're all good. And that, my friends, was adrenocorticosteroids.